Good afternoon. My name is Tim Dixon. I'm the Executive Director of the Pharmaceutical Industry Labor Management Association. And this is just another in a series of conversations and webinars that we've been hosting that further explores the partnership between the skilled unions in the construction industry and the innovative companies in the biopharmaceutical industry. For nearly 20 years, we have been forwarding this conversation between the skilled craft unions and the biopharmaceutical industry in order to preserve and actually develop skilled jobs in the biopharmaceutical sector, with the billions of dollars that the industry spends on research and development here in America, and at the same time, developing and bringing to market innovative new medicines like vaccines that help the economy get back after the worldwide pandemic. We have not been far away from discussing the supply chain, which is the subject of today's webinar, because it's an integral part of understanding drug pricing and the cost that patients and plan sponsors pay for the medicines that they need to keep their workers healthy. We're very fortunate today to have two subject matter experts, one from the Pharmaceutical Research and Manufacturing Association, Rachel Weissman, and Randy DeFrehn, recently of the National Coordinating Council of Multi-Employer Plans, and more recently, a trusted advisor and consultant to PILMA. I'll start with Randy. Randy has spent nearly 50 years in a host of positions in service to multi-employer health and pension benefit plans. For 16 years, as I mentioned, he served as executive director of the National Coordinating Committee for Multi-Employer Plans and was involved in the community's response to the implementation of the Affordable Care Act. He authored Cost Drivers in the Drug Supply Chain, which was a study that PILMA sponsored, and he'll be speaking to that today. And before we get to Randy, I'll just say a note about Rachel. Rachel not only is a senior director at PhRMA, where she is helps in the policy and research around the supply chain issues. She also spent a good bit of time at Research America, where she was a policy and advocacy manager that provided an analysis of various domestic policy issues and their potential impact on public and private sector, medical and health and research. And she also did several congressional briefings and monitored the congressional appropriations process. Stopping right there, I think I'll just go to Randy and toss to you, and maybe you can speak a little bit about the study that you developed and authored, and also maybe let us know what's changed since the time that you published that study, and what has happened to the supply chain since that time. So I'll stop there and let Randy get us smarter.
Thanks, Tim. I appreciate that. Could we put the first slide up? There we go. The drug supply chain, who benefits? Well, we're going to talk a little bit about the, other than the obvious being the patient, we're going to talk a little bit about the elements of the supply chain. We're bringing up to date some of the materials that I had prepared in that study that Tim had referred to a couple of years ago. I'm going to look at just an overview on the evolution of health benefits with respect to prescription drugs. Looking at some of the percentages of spending that's going towards healthcare from the GDP, how much of healthcare spending in total is attributable to prescription drugs, and then we're going to look at a quantitative analysis of some of the pieces of this, which Rachel is going to pick up and give us the details on. So with that, can we turn to the first slide? The primary links in the supply chain are the manufacturers, the wholesalers, the pharmacy benefit managers, the specialty facilities, which are both freestanding and inpatient, and the pharmacies. Just a quick word on wholesalers. Wholesalers are kind of an integral part of this. They purchase drugs from the manufacturers, so they have it available in quantities that don't make the pharmacies have to stock everything. Next slide, please. Looking at benefit designs. Now, I'm commenting on this primarily from a multi-employer perspective, although I think most of this is pretty applicable across the board. In the 50s and 60s, really there wasn't a whole lot of variation to what was covered by third parties. It started out as inpatient, and for those of you who might be close to my age, or at least have heard from your parents or grandparents, they didn't talk about health insurance in those days. They talked about my hospitalization, because that's really all that was covered. In the 70s and 80s, as work became more plentiful and unions were trying to negotiate better benefits packages, we began to see some limited drug plans. Frequently, they started out as mail order, and the earliest retail plans were modest with low copayments. I happen to have been around the mine workers when they were setting up their mail order drug program back in the mid 70s. And they had the U.S. Pharmacopoeia be the ones who decided what was on the list. So if we got into the 90s, rising costs produced a purchasing coalition. So groups could band together and negotiate discounts with manufacturers off AWP. And they did that through the engagement of pharmacy benefit managers. Of course, as time went on, their role expanded into formulary development and management and participating network negotiations. But one of the problems with them is that they became increasingly opaque in terms of their contracting practices. Next slide, please. So as we developed more into the 90s and the 2000s, we continued to see cost increases being a major problem. As we talked about how to control those costs, the economists said, well, what's really wrong here is that people have too many generous pension or benefit plans, so they need more skin in the game. In other words, they want to shift the cost to the participants. They did that through higher deductibles. They did it through applying deductibles before the drug copayments would apply, or the drug benefits at all, moving to high deductible plans with complementary health savings accounts. Now, high deductible plans were not as prevalent in the multi-employer arena, but there are some that are out there. One of the problems with having too much skin in the game is excessive deductibles leads to something called prescription abandonment. It typically happens when the prescription drug cost, the out-of-pocket costs exceed about $250. Next slide, please. Chronic conditions are important here when we talk about managing healthcare costs through a drug program. Chronic conditions are diseases that last at least 1 year or require ongoing medical management or limit the activities of daily living. 6 in 10 Americans have at least one chronic condition. 4 in 10 have at least 2. But here's another very sobering fact. 7 in 10 deaths in America are attributable to chronic diseases. Next slide, please. So how do we manage the chronic conditions as well as managing costs? Well, one of the things comes back to what I had mentioned earlier, prescription abandonment. Non-adherence to prescription drug management of chronic diseases can cost between 3 and 10% of the US healthcare spending. Hospital costs for type 2 diabetes can be up to 41% higher if you do not adhere to the drug regimen. And as far as the cardiac side of things, adherence to statin protocols can reduce hospital admissions for heart failure by 10%. Those are major cost savings to the system. Next slide, please. And what do those savings look like? Well, this shows a little bit about the total amount of healthcare spending during the period from 1960 to 2020. And this shows healthcare as a percentage of GDP. If you go back to 1960, it was about 5%. By the time we got to 2020, healthcare as a percentage of GDP is approaching 20% at 19.7. Next slide, please. If you take a look at what percentage prescription drugs are to the total healthcare expenditures, they started out at about 9.9% of the total expenditures. And as you take a look at the way these two lines track, you can see that the total healthcare costs really exploded as we got into the 70s, 80s, and 90s. And if you look at the prescription drugs, let's go on to the next slide. Part of the reason for a lot of the changes in expenses, not just on the prescription drug side, but for healthcare expenditures overall, it can be looked at here, where you can see the involvement of third-party payers. If you go back to 1960 and look at the prescription drug spend, over 90% was out of pocket. Over time, though, with the involvement of government programs and private health insurers, that number dropped to about 14%, with the government and private insurers carrying about an equal load in this study that ended in 2015 by Brookings. Next slide, please. So what does healthcare, what does prescription drug cost look like now as a percentage of the total healthcare spend? It's now down a little bit at 8.4%. Now, since the number itself is so much larger, it's a substantial number, but this is an important thing to see how this number compares to other aspects of the healthcare system. Next slide. So when we talk about expenditures, one of the things that first comes to mind is price. And there's been a lot of debate in Congress and with various administrations here recently that price is really the problem. Well, basic economics teaches us that price is a function of supply and demand. Next slide, please. Not necessarily in this arena, though. Next slide. Because we have to ask which price. Here are 10 separate definitions of prices that are used in the pharmaceutical arena. And what we have here is it depends on who is buying what from whom, which price you're using. One of the ones that's on here is the average wholesale price, which I mentioned earlier, that the pharmacy benefit managers were to use as a discount for the manufacturers when negotiating the lower prices for those coalitions that were set up. There's a group called 46 Brooklyn, and the guy who runs 46 Brooklyn made a reference recently to AWP as being ain't what's paid. And I think that's really the best description of it right now, because average wholesale price really doesn't reflect what's being paid. Next slide, please. So how much variability is there in pricing? Well, let's take a look here at buying the same 5 drugs at the same quantities in different stores. And this was a 2018 consumer report study where they looked at 5 drugs that were in what they call a basket of commonly prescribed drugs at 150 pharmacies in 6 metro areas. Their results were staggering, to say the least. If you take a look at the lowest cost, healthwarehouse.com, you could get those 5 drugs for $66. If you went to the next provider, at Costco, which is usually a pretty reasonable low cost vendor, the charge was $105. But if you looked at the same 5 drugs purchased through CVS or Rite Aid, the prices were closer to $900. Again, same 5 drug basket, but a markup of over 1,300%, the only difference being the retail vendor. Next slide, please. Specialty drugs is another concern. It's especially important concern these days because of the prices of the specialty drugs. But these are the drugs that are typically require clinical supervision in the administration, and this is the traditional definition. And they are usually given in an alternative setting and subject to an additional markup. They're specialty clinics for oncology, fertility, anemia, and other conditions. And many of those generally require prior authorization before treatment commences. Next slide, please. So let's take a look at how specialty drug pricing goes. And we'll take a look at how hospital-based specialty drugs. Certainly, there are price variations between brand and generic, as there are in every location. Point of sale and site of administration also make a difference. But Moran Company did a study of almost 3,800 hospitals and looked at their billed charges in 2016. And what they found was an average hospital medicine markup was about 479%. That's almost 5 times what's paid for it. The 53% of the markups of the facilities marked things up between 200 and 400%. 17% was a 700% markup, and 8% reported markups of over 1,000%. PhRMA did a study during those times, and I thought this was a pretty good quote. Medicines don't really perform 700% better in a hospital. Next slide, please. These studies on specialty drugs were conducted by 2 of the biggest PBMs, Express Scripts and CVS, and they showed that in Express Scripts study, specialty drugs accounted for more than half of the total spend under a pharmacy. Specialty drugs, though, are only used by less than 2% of the population. When ranked by total pharmacy spending, 17 of the top 25 drugs were specialty. CVS did a study the same year, and their results were very similar. Specialty accounted for 52% of the drug spend, and 5 therapeutic classes drive 95% of the spending in that category. Next slide, please. This this slide here shows the PBM market share by total equivalent prescription claims in 2020. And it shows that CVS, Cigna, and United Healthcare, those 3 large vendors represent 77% of all prescription claims. So they are the ones who negotiate the fees. They administer the claims they administer the discounts through the claims processing system. But they really claim that they really don't make very much money doing this. And so let's take a look at the next slide. There are a couple of different analyses here at the rate at which drug supply chains convert gross profits into earnings before interest, taxes, depreciation, and amortization. This is another one of those accounting kind of terms here, but I usually don't like to read anything, but this is actually very interesting. It's just about 2 paragraphs here. In a February 24, 2018 article in the Wall Street Journal called Hidden Profits in the Drug Supply Chain, Charlie Grant reported that the largest of the PBMs, Express Scripts, was expected to report profits of 4.7%, while CVS Health reported a loss of 0.28%, and United Health Group essentially broke even at 0.06%. He also reported, though, that these numbers appear to significantly understate the company's true profits, observing that their statement showed gross profits, revenue minus the cost of goods sold, of $1.8 billion on sales of $24.7 billion in the 3rd quarter of 2017. Because the PBMs rarely take possession of the drugs that they negotiate discounts for, he noted that fixed costs, overhead, depreciation, amortization, and administrative costs are quite low. This observation was supported in another study reported in Drugs Channel, which found that rebates and discounts have more than doubled in 2017, from 2012 to 2017, from 74 to 153 billion. Concluding that not enough of these rebates and discounts are making it to the employers and the unions that are sponsoring these plans, but rather being retained by the middlemen. With those considerations in mind, Bernstein Research, which is widely recognized as Wall Street's premier sell-side research and brokerage firm, performed their own analysis. Their methodology excluded the costs of drugs that are included in the revenue, the cost of the drugs that are included in the revenue, and then compared the rate at which gross profits converted into earnings, again, before EBITDA. And what they concluded was that the supplies, that the managers, pharmacy benefit managers, and other pieces of the chain, including distributors, insurers, and pharmacists, are really raking in a lot more than they admit to. And in this one, this is again the Bernstein results. PBMs are shown to have a profit margin of 85%. Distributors around 52%, insurers right around 32%, and pharmacies at about 20%. Now that glowing little green dollar sign in the corner says an awful lot. And as we start to look at the elements of this, I'd like to have Rachel turn this over to Rachel, and she can talk about the distribution of the dollars among the various links. Thank you very much.
Thanks, Randy. Hey, one question before we get to any groups, and just a reminder to the folks on the screen, if you do have a question, just kind of type in to the chat and we'll make our best efforts to answer those questions online. If we don't get to your question, we'll certainly kind of pull on the coats of our experts here to get you an answer offline. One question I have, Randy, is, as you know, since with your history and record working to improve union health and welfare and benefit plans, union rank and file members enjoy a very good coverage, right? They
Yes.
Their co-pays are low, their out-of-pocket costs are minimal. So if a PBM negotiates a rebate and pockets that rebate and doesn't pass that along, why does that matter to the rank and file member? Why is that important to them if their coverage is mostly set?
Well, if the dollars were flowing through, as many contractors with extremely large employers or some of the bigger funds work, those dollars flow back to the trust, and it reduces the overall cost of the plan itself. Now, there's been a lot of talk about having the rebates applied at the drugstore. But if you have a more traditional kind of benefit design, such as most of our plans do, the rebate could be larger than what the out-of-pocket expense is for the individual. So if we can have the rebate dollars flow through to the plan sponsor, it would be a much more effective way of doing it. Now that the caveat I would have for that, and I don't want to take any more of Rachel's time, but the only caveat I have is for those plans that have adopted high deductible plans, that could be a different scenario.
That's great. And just one follow-up, just to kind of lead the witness a little bit. If the plans are burdened by heavier costs, that will ultimately inure to the impact on the rank and file member in terms of wages. Isn't that pretty close to being right?
Right. Remember how these plans are funded. They're funded through allocation from the total wage package. So if you have to spend more money in your health fund, that contribution reduces the amount that's left over for your take-home pay.
Gotcha. So PBM's pocketing rebates and not sharing that with the plans will ultimately have an impact on the wage earner in terms of fewer wages.
A direct impact. That's correct.
Great. Thanks, Randy. Rachel, let's turn it over to you. I know that PhRMA just published a very impactful study that with a lot of interesting findings. We've known for some time that there's been this carve off of middlemen in the supply chain between manufacturers and the folks that actually end up with the medications. But PhRMA's come up with some interesting findings in terms of how big that impact is. We'd love to hear from what you've come up with.
Great, thanks so much. I'd be happy to go through that research. Thank you so much for having me. So I'm going to kind of pick up where Randy left off. As he discussed, there is a lot of different stakeholders in the supply chain. And these many players mean that there's many different flows of dollars going to and from each stakeholder at every stage of the process. And you'll notice in this graphic that nearly every stakeholder other than the patient has dollar flows going to and from them to another member of the supply chain. And this complexity makes it really difficult to understand the true cost of medicine. And that true cost differs based on your perspective. So to level set here for the purposes of this discussion, we're going to talk about two different measures of brand medicine spending. We're going to talk about gross medicine spending, which is the total amount paid at the point of sale. And so this is spending before rebates, discounts, and other price concessions, just the total amount based on the list price of medicine that's being spent. And then we're going to talk about net medicine spending. And we're going to define net medicine spending as the amount that manufacturers ultimately receive from the sale of their products. Next slide. So ultimately, rebates, discounts, and other payments made by brand pharmaceutical companies lowered gross medicine spending by nearly $200 billion in 2020. And on a per medicine basis, net prices are on average about 44% lower than the list price. So while you'll often hear about list prices of medicines increasing, I know I heard a lot of it this morning in the Senate Finance hearing, data shows that net prices have remained in line with or below the rate of inflation for the past 5 years. And just in 2020, net prices for brand medicines actually declined by 2.9% on average. And the study I'm about to go through is going to help rectify these different pieces of information and hopefully help you better understand what's currently occurring in the pharmaceutical supply chain. Next slide. So as Tim mentioned, earlier this year, PhRMA partnered with the Berkeley Research Group to update a previous analysis that decomposes the share of gross medicine spending that's going to each stakeholder. There are three main findings that I'm going to focus on today. The first is that more than half of every dollar spent on brand medicines is going to someone other than the company that researched and manufactured that medicine in 2020. And this is particularly notable because for the first time since BRG began tracking this trend 8 years ago, the share of brand medicine spending retained by biopharmaceutical companies has fallen to less than half. Second, the amount that payers, which here we're going to broadly define as insurers, PBMs, and government programs. So the amount payers have received from the sale of brand medicines has increased 180% between 2020 and 2013. And this growth in spending reflects growth in rebates, discounts, and other payments from biopharmaceutical companies that lower the cost of medicines. And third, the amount hospitals and other 340B entities are receiving from the sale of medicines purchased through the 340B program increased by a factor of 12 between 2013 and 2020. And this unprecedented growth is driving the overall increase in the share of spending received by healthcare providers. And we'll talk a little bit more about 340B in a minute, but first I want to double click on each of these three main points and provide a little bit more color. Next slide. So here we're looking at share of total gross medicine spending received by manufacturer and non-manufacturer stakeholders. Back in 2013, about a third of total spending on brand medicines went to someone other than the company that made the medicine. But since then, supply chain and other stakeholders have received a larger and larger share of total spending. And now over the study period, the share of non-manufacturer stakeholders, the share that they collected increased by more than 17 percentage points. Next slide. So this chart gives you a different look at the exact same data, but here we're looking at spending in terms of absolute dollars. So the amount of spending received by manufacturers has grown more slowly than total spending growth. And this means that other stakeholders are benefiting more from each additional dollar spent on brand medicines. Or in other words, the growth from year to year is primarily going to other stakeholders, namely payers and healthcare providers, rather than the manufacturers that are making the medicines. In the next couple slides, we're going to look at both, can we go back? Yeah. In the next couple slides, we're going to look at both payer and provider trends to understand the extent to which these stakeholders are receiving a growing share of brand medicine spending. But overall here, it's really important to note that as this trend continues to intensify, manufacturers are capturing less of each additional dollar spent on brand medicines. So one important note here is that this chart is looking at spending, not prices. And as you know, spending is a combination of price and utilization. So spending will go up if the price goes up and the number of people taking the medicine stays the same, or if the price stays flat, but more people take medicines, or both. But in this case, we know that the observed increase in net spending is being primarily driven by increases in utilization in new medicines. Next slide. And we know this because we can look at price growth trends over the same period. As I mentioned earlier, over the past 5 years, net prices for brand medicines have been in line with or below the rate of inflation. And over the same period, list prices have continued to tick upward, although very modestly in the past few years. But this difference between net and list price growth is contributing to the growing gap in net manufacturer revenue and gross medicine spending. And this gap is ultimately going to others in the supply chain. Before we talk about these others and the amount they're receiving, I want to take a quick pause because I want to make sure that I'm clearly conveying the intentions of this study. We as PhRMA are by no means arguing that we should be getting more of these other dollars that are going to other stakeholders. That is not the message that I want you to be taking away. Rather, the key message here is that there are many players in the market and they're all taking a piece of the pie. And to have a thoughtful, meaningful discussion about medicine spending, it's really important to understand holistically what's happening in the system and where the dollars are going. By just looking at manufacturers, you're only looking at half of the picture. So now that we got that out of the way, let's talk a bit about where that 50.5% of gross medicine spending is going. Next slide. So first, let's look at payer trends. We're defining payers pretty broadly here, as I mentioned. But since we began tracking trends in 2013, the amount received by payers has increased 180%. And for comparison, over that same period, the amount manufacturers are retaining increased by 43%. So we can also look at the share of annual spending growth going to different stakeholders. And we found that between 2019 and 2020, payers received the largest share of the total increase in spending. It's important to note that this amount reflects both fees and profit retained by payers, but also the share of rebates and discounts that may eventually be passed on to patients in the form of lower premiums or cost sharing. As Randy mentioned, it's often uncommon to have patients in more traditional health plans benefit from these price concessions at the point of sale. But what I really want to underline here is that it's important to recognize that this spending that is often characterized as spending on brand medicines is ultimately not ending up the manufacturers, but it's instead being routed through or retained by payers. In addition to payers, healthcare providers, including hospitals, physician offices, and pharmacies accounted for nearly a quarter of spending growth in 2020, which is nearly the same that went to manufacturers. Next slide. The growth in what hospitals, pharmacies, and other healthcare providers are retaining from the sale of medicines is particularly dramatic. Between 2013 and 2020, the amount more than tripled to $81 billion. And BRG found that this increase was driven by growth in the 340B program. And that amount retained by hospitals and other 340B entities from the sale of medicines purchased through this program was 12 times larger in 2020 than in 2013. And during the same period, nearly 95,000 contract pharmacy relationships were established, which was a contributing factor to this growth. So I said I would provide some more color about the 340B program, so I'm going to spend a few minutes doing that. Next slide. I realize that the 340B program may not be super familiar to many of you. It certainly wasn't familiar to me before I started this role. So I'm going to do a very quick 101. The 340B program was created about 30 years ago to support safety net clinics and qualifying hospitals by establishing discounted medicine programs funded by biopharmaceutical manufacturers. And the aim here was to help vulnerable patients access medicines at these safety net providers. Back in the early 2000s, you can see that this is largely what the program looked like. It was evenly split between community clinics, also known as grantees, and community hospitals. However, today the program has become largely unrecognizable. And this is because profit incentives have fueled rapid program expansion, particularly by large hospital systems. And this is often at the expense of patients' well-being. What was meant to be a safety net program for a small share of hospitals has grown so much that now 40% of hospitals in the US are currently 340B hospitals. Next slide. So how does the 340B program work? So this program requires manufacturers to pay qualifying hospitals and clinics deep discounts that average about 59% on outpatient medicines. In some cases, these discounts are so cheap that they can bring down the cost of medicine to just about a penny. And at the 340B discounted rate, these entities are able to retain the difference that's ultimately charged to insurers and patients. There's no requirement for these hospitals to pass on these discounts to patients, even though the intention was originally to serve underinsured and uninsured patients. One report, so while there's no requirement placed on these hospitals, they are permitted to mark up the cost of medicines to both commercial insurers and uninsured patients. And one report found that 340B hospitals charge commercial insurers and cash paying uninsured patients nearly 3.8 times the cost of their cost to acquire the medicine. Next slide. So as hospital programs understood the potential profitability of this program, it grew exponentially. And today, the 340B program is actually the second largest federal drug pricing program, behind only Medicare Part B. Before I shift gears one more time, I wanted to give that quick overview of the 340B program because it's really becoming a major driver of medicine spending in this country. Next slide. So before I open it up to questions, I want to preempt one of the most common questions I get. I'm often asked how this breakdown in manufacturer and non-manufacturer spending compares to other industries. And this is a totally valid question. If this is just how it always works, then there's nothing wrong here. So we did some digging into other industries to see how they lined up to what the pharmaceutical industry was witnessing. Next slide. So when compared to other peer high R&D manufacturing industries, the pharmaceutical industry was an outlier in that we invest a considerably large share of our revenue into R&D while retaining a comparably low share of total spending on our products. And this scatter chart is showing the share of total spending on products received by the manufacturer on the vertical axis, and then the R&D intensity on the horizontal axis. And you'll see that not only is the pharmaceutical industry among the highest in terms of R&D intensity, but it's the only industry with both high R&D investment and retaining a relatively small share of total spending, making it an outlier among other comparable industries. So I went through that very quickly. I wanted to make sure to get all that in. So I will go ahead and pass it back to Tim.
Thanks, Rachel. That's very informative, and I don't think you blew through the numbers too quick. I think it's readily understandable. One thing that caught my attention was you said a thoughtful, meaningful conversation about policy and price would kind of reveal these things. Yeah, it's an election year, so thoughtful and meaningful policy conversations are not too common. But I did notice today that the Senate Finance Committee was holding a hearing on pricing. No legislation to come out of it, just a hearing. Did this come up during the Senate Finance Committee? Anything about the role of middle players in the supply chain?
Well, as far as I know, I think it's still going on or just about wrapping up. So from what I watched, it seemed pretty laser focused on both the proposals in BBBA, so government negotiation, and list price increases, which is unfortunate. There was a lot of misinformation around the value of medicines to patients, which is something that we really need to work on communicating, because oftentimes medicines that enter the same class are viewed as kind of just another follow-on when they actually provide very real and meaningful differences for patients. So that's a really pervasive misunderstanding that was common in this morning's hearing, which is unfortunate.
I would add, though, I mean, first of all, PILMA has had a position on sharing the savings for many years now, and as has PhRMA. And I would note that of late, there have been some actors in the health policy arena, in particular, Senator and Chairman Wyden, Senator Sherrod Brown, who have at least started this conversation about taking a look at PBMs. Are you hopeful that this conversation can broaden enough that we can really start talking about a holistic look at the supply chain?
You know, it depends on what day you ask me. Today, I'm feeling a little cynical after the Senate Finance hearing, but it feels like we are starting to make headway in educating policymakers on these issues. And I think that it's really, education is critical when we're talking about these really complicated issues. And I think that, right, I hope that policymakers are starting to understand that it's not just manufacturers that are involved in this sector, and there's a lot of players that are all influencing the price. So hopefully we're on the right track to have a meaningful conversation about this.
Yeah, and just to follow up on that, I did note also, or we did notice that the Federal Trade Commission at least had an attempt to take a look at in investigating the role of PBMs in the supply chain. They're not fully impaneled. I think they're missing at least one commissioner. So they ended up in a kind of a jump ball, a tie vote on whether or not they would take this up. But they did start a comment period that addresses PBMs and supply chain. What can you tell us about that comment period, how long it lasts, and kind of what's the subject matter there?
Yeah, so this was a really interesting opportunity to comment. The FTC asked some really interesting questions around PBMs and their role in the market, both as far as consolidation, both vertical and horizontal, but also about PBM's role in influencing what medicines patients take. So looking at things like utilization management and cost sharing and other formulary benefit designs like pharmacy retail networks and steering patients towards specialty and mail order pharmacies. So there's so many different tools that PBMs use that influence the entire supply chain. And so we see this comment period as an opportunity to really dive into those issues that are really not well understood, partially because we don't have access to data and we don't have access to really transparent contracting or anything of this the kind that would allow us to have a sense of what's actually happening in the system, which is part of the problem and why we think that it's important for FTC to take a close look at these issues. So I think, don't quote me on the date, but I'm pretty sure it is due towards the end of the month, if not early next month. I know we are internally getting our draft done next week, so that's the date in my head. But I definitely encourage groups like PILMA and other groups to put together comments and submit comments. I think that providing a diverse view of these issues is really important as FTC starts to take more notice of them.
Well, I think that you can count on the PILMA, since we have a very clear lane here in the policy space on sharing the savings with plan holders, plan sponsors, and actual patients. Randy, you and I can work together with the entire team to kind of develop some of that. Rachel touched on something that I think would be good just to mention, Randy, in terms of the question I would have is, why would labor unions care about this process? And two, what can you say about the opacity of the PBM role here? Why don't we know more about what what they're kind of raking as the drug goes from manufacturer to patient?
Well, if you take the first part of that question, why should labor care? It comes back to the question you were asking before about how the trust funds are funded, and anything that any of the costs that go to the trust funds are directly paid for by the workers. So it's a very clear pass through of any savings that we would have would go to would accrue to the participants in these plans. On the second question about the PBMs and the opacity, this is something that when I was at NCCMP we battled for a long time when there was a discussion about whether trustees should look at every aspect of the administrative costs for 401k plans, and they were talking about the big money managers and how they would say, well, we'll do the administration for free, when in fact you knew it wasn't for free. They were charging something there. We went on record at the time and say that we should have the same standards for pharmacy benefit managers. They should have to disclose their costs for the services that they provide. And really what it should come down to is that they should be on a fee-for-service basis. It's relative to a point that Rachel was making earlier, the value of the services that they provide. Because right now they're being paid far in excess of that value.
Well, thank you both, Rachel and Randy, for this very informative session. I would add that PILMA has consistently leaned in on these very important issues, because not only does it have to do with the fact that unions stand to care for their members and their health and well-being, but the health and of the ecosphere and the industry helps put skilled men and women to work on the job site every day. As one of the largest employers in the industry domestically, we stand ready to go to work on the job site with good paying jobs, good wages, and good benefits. So it helps for us to get involved. we will, to the folks that are watching, we will make sure that we circulate our resolution on the supply chain and make sure that you know where we're at, and we'll be ready to make commentary and lean in terms of advocacy on this very important issue. Thank you both, and thank you all for joining us. Look for the near future. We'll get into another conversation on labor industry insights in the biopharmaceutical sector. Thanks again, guys. Really appreciate it.
Thank you.
Thank you for having.